is the Chief Executive of NHS Highland and has been there since 2011. Before that, she was the Chief Operating Officer. Hopefully, you can manage at the lectern. I should have probably said, because obviously there's a lot of slides here, as we'd said, we were filming this, all of the materials for today will be available online. So not only the slides, but also the filmed presentations. So that's something that you'll be able to get into. Elaine, interestingly, is going to, and I won't keep her standing on her feet too long, but one of the things that came out of this morning was people kept saying to us, okay, what do we do? How do we do this stuff? Give us the menu of things that we need to do. And I think Pedro's presentation has given you some idea around how these things are done. What's going to be really interesting in this is you have Elaine, who has done quite a lot of this stuff in NHS Highland already. And that, I think, will be very useful for us in terms of thinking from the slightly theoretical to the practical and Scottish context. So I'll hand over to Elaine.
Thanks very much, Linda. So thank you very much for inviting me to talk to you today about actually our quality journey. And this is about the Highland quality approach. It's about us putting quality first to deliver better health, better care and better value. But I need to get something out of the way first. Some of you that will know me will know that I've been participating in the 50 Days to Fit. I didn't break my ankle doing the running that goes with the 50 Days to Fit. I did it getting the bag out of the boot of the car, having had the run. So I am counting it as a sports injury, and I won't be argued against. Okay, so now you can all concentrate on everything else. Now you know what I've done to my ankle. Be fine. So the Highland quality approach actually captures then the spirit of working to improve care and outcomes. And it resonates actually with something Martin was saying today, because we try and capture that. It's very difficult to say what is it, but it's actually how we want to do things here in Highland. So I want to talk to you just a little bit about the snakes and ladders that we've gone through, the visits that we've been on, and the bottom left-hand corner will describe for you then some of the red herrings that we've had to deal with. So it is a journey, and we are on that, and we've been on it actually for some time. So this isn't a quick fix at all. I want to really always look forward, but in order to look forward today, we need to look back a little to see where we've come from, because all of you in Scotland have been on that journey as well. You just may not necessarily recognise some of that. So we have a number of constraints, the things that we're looking at on the left-hand side here. We have the additionality of the complexity of remote and rural services that we're having to deliver, but everything on the left-hand side here we've been talking about today. And we're trying to organise those on the right-hand side into the priorities, the values, the methods, and then the sustainability of the services that we need to provide. The triple aims then for us was something that underpinned everything that we did quite a long time ago, and again it was in the board ambition and the statements for us by putting quality first as better health, better care and better value. And again I hear today people are saying we're not quite identifying with those triple aims. My guess is you are actually. You are doing that. When you're talking about co-production, when you're talking about population health, all of you will be using this, but you'll just maybe not be absolutely calling it in the way that Pedro's described to you today. But we had this as a strapline quite a long time ago, and it's been helpful to us to come back as a touchstone to keep us focused on our journey. Integration is something that we've done in Highland, and lots of you will know that, but this was about integrating health on health before we started integrating anything else with anything else. And that's still a journey for us. So we're now on a journey of redesign, looking at how we can continually look and transform our services. And we do that, we need to do that in collaboration. On the left-hand side, we've had a number of the same collaborative programs you've all been working in. And on the right-hand side, here are other colleagues that we've been working with over the years. They won't necessarily be familiar to you, but these are people that we've worked with who've come to us with ideas, who we've gone and stolen their ideas shamelessly and brought them back into Highland and tried to make it then something which is recognisable for us in Highland. And the journey continues. I've put this up and one to come on A&E Waits just to show you that actually it's the same journey we're all on. The emergency inpatients now have been going down. We would have expected them to have been going up over time. That was our expectation. So this work started a long time ago. Every piece of initiative that you've put in place has helped us now with the emergency inpatients and trying to prevent people being brought into hospital. Again, we've all had the experience of reducing the elective inpatients and seeing day cases going up, but that's showing us that healthcare is continually changing. Again, compliance with the 4-hour target, we wanted to try and make sure that we didn't just focus on hospital care, we looked at the whole system, the whole flow, and that's helped us try and maintain our A&E wait times to what are reasonable still now. But you still get caught out if there are blocks in your system, if there's flow problems up or downstream, and you have to look at this as a whole system. So I take you back to Cotter, where we started, and Cotter gives you these 7, 8 stages for action to take cognizance of. And we started very early on building that increased urgency, not just a burning platform, but actually something that people would buy into. And it's very difficult. If you think that one of these steps, one of these actions could potentially take you a year or more, it's a long journey that we're on. And I'll come back to this at the end. So back here in 2008 then, we were looking at how we recognised straight away that imperfect systems cost lives. And this was, as you realise, time for us to be talking about the beginnings of the Scottish Patient Safety Programme. And we also had something I put up to our board, which was a black hole. That was potentially what the finances were looking like for us at that time and still now. So we recognise, though, that efficiency without quality would be absolutely unthinkable, and quality without efficiency is unsustainable. So you can't take one away from the other. You need to look at quality and you need to look at finance together, but it's the focus you need to give that. So but on November then, we had other catalysts for change, the 18 weeks RTT we touched on today, financial pressures. We saw that as a real opportunity for change, not just a threat to our status quo, but a real opportunity for change. And back then we were saying, what do we need to do? We were talking about maximising the use of everything that we had, the talent, the assets, the contracts that we have, understand and reduce variation, and most importantly, stop doing things to patients that are of no clinical benefit. And you'll realise at that point we're still talking about patients. We hadn't moved then to talking yet about people. We, as a number of you, had a strategic partner, as was GE, and we worked very closely with GE over a number of months and years, actually, and we found we had some real success in small pockets, and I guess a lot of you would have had the same experience, but we couldn't get the traction. We couldn't manage to embed that across the whole of the organisation. We found as well the clinical engagement that we had from the Scottish Patient Safety Programme, that standardised approach for measurements, that absolute engagement gave us another thought about how we might want to take forward our improvement work. And we started looking again at what makes improvement work. It is about leadership. Again, you've heard already today, it's about clarity and consistency, and it is about measurement, having something you can actually measure and show back to people. So we wanted to invest in quality improvement tools and techniques, and actually, even when times were hard, invest in training. We were also compelled by the no needless deaths from IHI. This resonated with us as a board. Actually, what were we there for? And we recognised when we were talking to our clinical colleagues, people actually bought into this. They understood what this meant. They didn't want to have people waiting. They certainly didn't want any needless deaths or pain. But the no waste was an interesting one for us to explore in a bit more detail. And we wanted no waste for anyone. So on to November 2011 then, we decided to try and encapsulate what we were doing with 7 characteristics of service delivery for the future. And I'll go through these quite quickly, but what was interesting about these as we started to describe them, again, nothing here you won't have heard of or thought of before, but we had some quite harsh targets behind that for ourselves. We had some statements we were making behind these that were saying to people, this is actually what we're going to do in Highland. So promoting good health, self-care, independence, high quality integrated and effective care, community-based services. Again, all of these will, I'm sure, have resonance for you. Integrated and complementary care with the local authority, voluntary and independent care sector. We wanted staff that were motivated and well-trained, working to maximum potential. And we were going to encourage people that weren't able or wishing to do that to help them out of our organisation. And that was quite a radical thought at that time. Some of our assets are absolutely beautiful in Highland, but simply not fit for modern day purposes. So we'd be then moving away from these sorts of assets into new, more flexible, efficient green assets, as we've got here in Invergordon. And that's actually a journey that we're on now. So we need to look at the waste that we've got in our services and try and reduce the overheads that we can then transfer into direct patient care. So there was a moment for us which changed everything that we did, and this was Leslie Ann, who was fortunate enough to undertake the IHI Fellowship, and a number of you in the room and elsewhere have been to Boston in Massachusetts for a year of intensive work as part of the fellowship. And that exposed Leslie Ann and colleagues to actually seeing best-in-class services, and she was feeding that back to us. As we were on a journey in this country, Leslie Ann was finding out about what was happening across not just America, but wider than that as well. And we went over to see it for ourselves. We actually spent some time in the feedback from the fellows. This is the IHI building in Boston. You can see even on the walls they have painted actually timely care, patient-centred, and everywhere you go there are inspirational comments painted for staff and visitors alike. I was lucky to be there the very night that the Boston Bruins won the Stanley Cup, and that will be something I won't forget forever. I've never seen ticker tape across a whole city, but this was quite extraordinary, and it looked like the whole of Boston stopped completely for at least 24 hours. But what we actually did sitting in Boston, and I almost didn't share this with you, but this, I'm afraid, is the reality of drawing a strategic framework on the back of a napkin at breakfast. And what I've highlighted to you actually is that many years ago now, some of the things that we aspired to do then, to have 100 change agents in our organisation, to actually develop our own quality hub, to go on visits, to explore, to be curious, to actually have something where we explain to people what was going on. At the bottom there, having a wall that we walked every day and looked at information. And on the right-hand side, changing the culture, but having what I've heard, again, a number of people say, and Pedro mentioned it as well, the bold and audacious goals that will stretch people to do maybe more than they ever thought was possible for them. So we've been working on this. We've probably tidied it up just a little bit, but I guess that you've all got paper napkins like this somewhere in your organisations with strategic plans on them. And we built on that. We sent then a number of people off to Paris 2012, and I think June was saying earlier this was the genesis for this meeting today. So things take some time to become embedded, but we sent a couple of people over, a number of people over to the IHA conference in Paris. And what really struck a chord with me was Don Berwick at that conference talking about the 3 questions he asked every single thing. Whenever anybody approached him, he asked, how would this affect quality? How will this affect the poor? And how will this affect costs? And if that isn't the triple aims there for all of us, and I'm sure, again, we're asking those questions back in our bases every day. So I wanted to just show you, we translated that into quality objectives. What they say around the outside doesn't particularly matter to you, but it's really to link into the fact that we try to put that right at the centre of all of our objectives. Those then are cascaded through the organisation. And we then looked for who was best in class at some of this work. From the work that Leslie Ann had done, she linked us into Virginia Mason Medical Centre. And we realised that they'd done something quite important about translating the Toyota production system, the elimination of waste, into something that was there and working for everybody to see in an acute hospital setting. So we sent a couple of folk over there. In fact, what I did was sent 3 clinicians to Virginia Mason to see exactly what they were doing over there. I sent an enthusiast, a complete skeptic, and somebody who was sitting on the fence to tell us, was it all fluster or was it real? They actually went and participated in some of the RPIW work, the rapid process improvement work. They spoke to staff. They came back and they said, we've got to do this. Exactly the experience that Martin had from his own clinicians, saying to us, there's something in this, for patients. We need to change the way we're working. We then, from the work that Virginia Mason had done, we then captured our strategic framework in this triangle, and you'll see this a number of times as I go through, having a quality approach that actually then encapsulates our vision, our mission, and our values. It was something quite tangible and quite easy for our staff to understand, but it took quite a long time to get it to this format. And while we were getting it to this format, we then needed a golden thread. Again, I'm not expecting you to be able to see the detail of this, but you can see from left to right, we had a strategic framework. We had the service characteristics then that were quite clear. We had the corporate objectives that were running through everybody's work, and those fed into our then 2014 plan. So not just a plan just for one year, but for a couple of years. So there was a direct line of sight between what we were trying to do every day and what actually I was doing in my job, wherever I worked in NHS Highland. So the culture was probably the trickiest thing for us. This was predating the culture and values that was coming out of NHS Scotland, which helpfully we've aligned with. And there was a lot of conversation about how do we justify our behaviours. And we've done some customer care work in a number of parts of the organisation to try and capture what the values would be in our strategic framework. And this justification of our behaviours with a but was summed up by our customer care team working in outpatients that told us that actually is my butt more important than your butt, and no patients came to any harm in the making of this slide, you'll be glad to know, but it did actually get to the essence of what we were doing. And one of our orthopaedic surgeons with our director of nursing led this work and actually managed to completely revolutionise the way they were working in outpatients. No longer are people popping in and out. No longer is it okay for your thing to be more important than actually the patient. And it's completely changed the way our clinicians are interacting with their staff and with the patients. We also wanted to be very open and very honest and connect, so we've been using patient opinion for some time, and we also probably have got a bigger circulation than a number of the papers in Highland now through our Highland News that we bring together and pass on to the population in Highland. So Highland quality approach brings together governance, improvement and culture, and I want to go on to talk about why we got where we were to North East England when we went down and visited Martin and his team at Tees Escombe Weir Valley, and developed an infrastructure then that looked then for us at providing a completely different approach. And the most important thing for us was to get people back out onto the Gemba, as Martin was describing, so they could see and touch exactly what was happening. We've trained a number of lean leaders, we've got a number of directors, senior clinicians and now managers. We've been undertaking rapid process improvement workshops with significantly more this year. And we've now had awareness training for over 2,000 people in Highland, with our lean leader training being linked into Tees Escombe Weir Valley and joining now in developing a number of coaches. So if I quickly whiz you through the reality of doing one of these, this burden of work that is there and apparent in everything that we do is something we try to look at through a piece of work in the breast radiotherapy RPIW. There had to be focus, and this was about giving patients now false hope around their waiting times. And there's a lot of fun in this. It's really hard work, but the trick is that it needs to be rapid. There's patient engagement in everything that we're doing. This was Laura, one of our patients, actually keeping us right through the week. And although I was being argumentative with the coach here, they did finally give me a certificate for doing the RPIW work. And that comes from working actually there, seeing it with your own eyes and actually touching everything that you're doing. So integrating care means that distracted us for a short time, but we've had a huge journey on that, and we've managed to take the RPIWs now, learning from what Virginia Mason did, and our work with Tees Escombe Weir, now out into other parts of the sector. So we've done RPIWs in care at home, we've done improvement work in mental health, we've got systems in primary care working. So this is only a snapshot, we're very small steps on our journey, but it shows you this is entirely applicable across any system that you'd like to look at. It's about the focus then. I've given you some examples of a clear focus and determination. It's about changing the culture, and then it's about finding what will be the right tools for you in your organisation for a methodology, but you need to stick with that methodology then. So the Highland quality approach has been tricky. We've had some developments, but I wanted to get straight to the key messages. I would say have a clear sense of purpose and live by those values that you describe. You need to build that quality improvement capability. And importantly, because we're very bad at doing this, we need to celebrate and reward success. It's not easy to do this. We know that this is actually a marathon and not a sprint. And we often are going to be pushed away from the journey that we're on. We were helped this year. We were one of those boards that was helped with some brokerage. And that meant that actually for all the effort we were putting into our improvement work, we still hadn't managed to get enough traction, even though we know that quality care is cheaper, we still hadn't managed to get far enough down our journey to get to the point where it was easy this year to balance our books. So we keep sending people away. Linda's pledge here was she's going to use what she learned, she's going to model the behaviour she wants, she's going to connect emotionally, she's unfortunately going to be a rebel, a radical, but not a blocker. And that has to be really good if people are away and being inspired by these sorts of things, from touching and feeling the other ways that people are doing their work in other organisations. So I would say to you, we're inching up that framework. We're at the point now where we will not let up. This is gathering some traction of its own. And the last thing I think we all need to do is to hold our nerve when we know what we're doing is the right thing. Thank you very much.
Thank you, Elaine. Is there time for Elaine to take some questions, or possibly Pedro? Or do we need to go straight into the table discussion? I'm looking at June. 5 minutes for questions. Are you all right? If you could just sit there, Elaine, and if anyone wants to ask you a question. So, Joe, you've got a question.
Just to ask Elaine, how do you align the national programmes into your framework?
We have aligned those, so both the Scottish Patient Safety Programme and all of the productive series are actually working parallel with the quality improvement work that we're doing around Lead. And what we're trying to find is a common language between them. So actually the Plan Do Study Act was something that everybody understood straight away. So it's just making sure you're using the right tools and techniques for the right thing that you're doing. And that really, for me, is the really skillful work.
Anyone else? Any hands? Yes.
Completely different culture. And in fact, undertaking some of the RPI governance that we've done in now joint teams, both around care at home, as I was giving you an example there, the social care team have completely embraced the methodology. What we found is that we can't hold them back with the ideas that they have. So they almost feel like they've not had an opportunity to say how they could do things differently and better. So we've opened that up now. And they've got absolutely fantastic ideas about how we can do it. So openly and embrace it, I would say.
Yes, Heather.
Sure, I'm just interested, do you find the tension between allowing people to understand terms to connect budget success to using lean principles, and a sense of wanting to control all the control what people are doing, or make sure that those tests are aligned and you don't end up with neighbouring wars with the standardisation actually where you innovate and understand.
So we've learned from SPSP in that way about making sure we roll that out so we get reliability before we then push that out. But we're actually keen not to reinvent something everywhere. So I think it's having that clarity for people. I spend a lot of my time on the Gemba, so do my executive team now. And a lot of that time is spent saying to people, on you go, try it. So we're trying the small tests of change, but the Highland quality approach and the strategic framework that I've shown to you today gives people then clarity when they've actually said, we know exactly how we can do this better. And the changes that they can make in a very short period of time are absolutely fantastic.
We'll take one more question if there is one before you get a chance to have a chat around the tables again. Anyone else got a question? Joe, again.
Can I ask how you've included the things like OD and finance and all the elements, all the aspects of quality in this work?
So, so we've done it in two different ways. So we've actually, one of the most recent pieces of the plan that we've been doing is actually it's in the finance process list. So it's actually going back to some of the principles about where this happened. But equally, what we found is that if you can get people to work with you, so our director of finance is out on the Gemba this very week doing an RPIW in the Life Sciences Yard. And Nick, I'm sure, will be coming back, as he has already, saying you can't believe the sorts of waste in that system. The waste being the burden of work and the systems that we put in place. Nobody's designed a system like that out of badness. It's just historically how we've organised ourselves. And when you look at that from a patient's or a person's perspective, actually it becomes very clear how you can do it differently. So we try to align it by actually engaging everybody in everything that we're doing.
Okay, just to point out that thank you to Elaine and Pedro for that. And you're now going to have another conversation around the table with your table hosts. Can I again urge you to fill in your pieces of paper while that conversation is going on? Also to point out that if you did have any burning questions that you didn't manage to ask, stick them on the piece of card, because when we do have a very brief coffee break, your table hosts will be bringing those pieces of card to me to maybe put to the panel after the break. Can I suggest that we try and pull back a little